Well, welcome to today's talk. It's Sunday the 6th of March. Now, let me just show you a slide to start off with here. This is Santoshi Omura, and this is William Campbell. And of course, they co-won the Nobel Prize in 2015 for the discovery of ivermectin. And I really think this is going to be one of the huge scandals of this pandemic. So people that call ivermectin horse paste, well, it won a Nobel Prize, for human medicine, of course, as it's revolutionised some aspects of parasitology in poorer countries. So I want to look at a couple of studies. This is the first study I want to look at. Well, actually, before we go to the first study, let's just look at this. This is remdesivir, which is one of the current antivirals. And we notice it costs £340 per vial. So not exactly cheap. Ivermectin here, this is the WHO list of essential medicines. And this is on the WHO list, and it costs literally cents per tablet. Now, I do know that there's been a fuss in the United States about the cost of ivermectin, but between you and me, I think the insurance companies are being ripped off a bit because it's dirt cheap to make. They make it by the kilo in India, and it's essentially free. It costs as much to wrap up in packages and blister packs as it does for the actual drug. So if you're actually paying the real price of it, it's very, very cheap. So there you go. That's the list that's the UK reference there, the British National Formula, which is the definitive text. And there's the WHO list of essential medicines. So no need to take my word for it at all. Please don't. And then we'll look at this study now. Now here's this study here. Treatment with ivermectin is associated with decreased mortality in COVID-19 patients. Analysis of a national federated database. Now, this is a conference paper presentation, and the authors are based in Miami, which I think is in Florida, isn't it? So interesting. We haven't got a lot of detail, but what we have, the detail we have got, limited, but it is really quite interesting reading. Always a bit frustrating with conference papers. You would like a lot more information. Very often they do publish more, but I can't find it for that one yet. So anyway, that's the link for that. Don't take my word for it. Check it out. Purpose of the study: to evaluate the difference in mortality. And this is in patients treated with ivermectin versus patients treated with remdesivir. So dirt cheap ivermectin, Nobel Prize winning drug, remdesivir, expensive antiviral. Now, this was taken from 44 healthcare organisations and 68 million potential patients in the United States, and the data was collected from the 1st of January 2020 to July the 11th 2021. So that's about 18 months, isn't it? Quite a long time. Now, the materials and methods: retrospectively identified diagnosed adults, recorded use of ivermectin but not remdesivir. So these had ivermectin but not remdesivir, making the ivermectin group. And then they recorded the use of remdesivir but not ivermectin. So they were mutually exclusive groups. So in other words, we have an ivermectin group here and we have a remdesivir group here, and we can compare and contrast these two because they were mutually exclusive groups. So it makes perfect sense. It's a well thought out study. And they controlled for what you'd expect: comorbidities, treatment and treatments that may affect COVID-19 survival. So they looked at age, gender, race, ethnicity, nicotine use, diabetes, which we know is a big factor, obesity, chronic lower respiratory disease, ischemic heart disease, whether they took tocilizumab or not. That's the monoclonal antibody that was quite popular for a while. Glucocorticoids, which of course are the steroid drugs, and whether the patient was ventilated or not. And the primary outcome they wanted to assess here was fairly simple: did the patients die or not? So that's the main outcome of the study. Did more patients survive? So primary outcome: mortality. Significance, of course, was taken at p equals 0.05, which is standard for all scientific medical papers. Now, results: 41,000 patients who had COVID-19. So 41,608 patients had COVID-19. Treated with ivermectin, the group there was 1,072. Treated with the much more expensive remdesivir, 40,536. So again, we've got two groups now. Clearly, there's a lot more in the remdesivir group than in the ivermectin group. But a group of 1,000 is really quite a good group. Well, not good. You want a bigger group as you can get. But it's a good-sized group on which to do statistics. You get very, very valid statistics from a group of that size, of 1,000. Ivermectin was associated with the reduced mortality versus remdesivir of the odds ratio of 0.381. In other words, you're about 70% less likely to die if you take ivermectin compared to taking remdesivir. And the p-value there is 1 in. Is that 1 in? That's 1 in. So that would be 1 in 10. That would be 1 in 100. That would be 1 in 1,000. So that's 1 in 10,000. So the results of that arising by chance are 1 in 10,000. Very unlikely to arise by chance. So ivermectin was associated with reduced mortality versus remdesivir 0.308. So there you go, about 70% less likely to die if you had ivermectin compared to remdesivir in this study. It's pretty convincing data from national databases. Conclusion, directly from the authors, ivermectin was associated with decreased mortality in patients with COVID-19 compared to remdesivir. Yep, that data shows that unequivocally. Ivermectin was associated with decreased mortality in patients with COVID-19 when compared to remdesivir. In future, more publications are published with the similar result to the current analysis. The certainty of evidence will increase. Now, of course, these authors do cover themselves with saying we always need bigger, better trials, but of course, who's going to pay for those? Because there's no money in this, so no one's going to pay for it. It really is as vulgar as that, I'm afraid. There is that study going on in Oxford, but it hasn't been reported yet. And there was something strange went on with that. The supply of ivermectin stopped and then it started again. But anyway, it's not reported yet. So the point is, we've got this accumulation of clinician-led studies. You do find this with most of these ivermectin studies, they are clinician-led, as is this next one here. Now, this next study we want to look at is prophylaxis. So this shows that patients treated with the previous study shows that people actually admitted who were already sick, if they were given ivermectin, they were much more likely to survive than if they were given remdesivir. This is on prophylaxis, but they did follow through to hospitalisations and deaths as well. And it's all really convincing. Less people with ivermectin got the infection, less people were hospitalised who took ivermectin, less people died who took ivermectin. But don't take my word for it, we're going to look at the study. So here's the study here. It's peer-reviewed. It's a peer-reviewed study, and these people here are mostly independent. Well, they are scientists and clinicians, because a lot of this research is clinician-led, because the pharmaceutical companies don't carry out research into ivermectin that I'm aware of. Why should they? There's no money in it. Anyway, this is the study we're looking at. Yeah, that's the last one. Sorry, this is the study we're looking at now. So in this study, they invited the entire population of Inja, this city in Brazil, to a medical visit to enrol in the program. So the whole population was invited in this city in Brazil. Not a sample, the whole population. Ivermectin was offered as an optional treatment to be taken for 2 consecutive days. 2 consecutive days. Every 15 days at a dose of 0.2 milligrams per kilogram per day. Now, this is a very small dose. This is the smallest dose. So doses double this or treble this have often been used. So if we see an effect here with this very small dose, it's likely to mean that ivermectin is indeed having an effect. And we'll see that it does, even at this very small dose, 0.2 milligrams per kilogram. Study analysis consisted of comparing ivermectin users with non-ivermectin users. So some people took up the offer, some people didn't. They ended up with users and non-users. Now, the precise data, of course, is given by the study. And I liked this study, actually. It's very very, very readable. Quite, you don't. A lot of studies. How likely would you recommend this article to appear? Yes, not just now. We'll do that after. So, quite readable study. You get the impression that some authors of some studies, the CDC is particularly bad. You get the impression it's written not to be understood, whereas this is clear, and clearly they've had help, or they're very competent in English already. And anyway, down to the results. 223,000 citizens of Itaja were considered. They actually picked an N of 159,561 to include in the analysis. Good number, very good number for research. Very good number. The first clinical trial I was involved in was called the International Study of Infarct Survival, way back in when was it actually? It was about 88, 89. And internationally, we recruited 36,000 patients in that trial. That was looking at the effects of the early drugs to break down clots in the coronary arteries. I mean, in my centre, we probably only recruited maybe 50 or 60 patients, but that went all together. And probably more than that, probably about 100 patients. But it all went together, 36,000 patients internationally. And that was a big study. This is way bigger. This is way bigger. This is a really, I mean, in research, these are just like huge numbers. So 159,000 people included in the analysis. Excellent numbers. 113,000 opted for regular ivermectin use. So we had 113,000 with regular ivermectin use, and we had 45,000 in this study non-users, 23%. This is of the 159,000. So again, you can see very good. It's prospective as well. We've got comparing that group to that group. And it's prospectively collected data. So we've got two excellent groups to compare. Now, looking at infections first, of these, 4,311 ivermectin users were infected. So this is looking at infections first of all. Who got infected? 3.7% in the ivermectin group, and again we said it's a low dose. 6.6% in the non-users group. So 3.7 got infected, indicating that looks like there's a prophylactic effect of taking even that small dose of ivermectin fortnightly. 44% reduction in COVID-19 infection rate. In other words, a big protection effect apparently there from taking ivermectin. Risk ratio initially was 0.56, which is pretty good. So that's what, well, it's as we say, a 44% reduction. The regular use of ivermectin led to a 68% reduction in COVID-19 mortality. So moving on to mortality, it was a 68% reduction in mortality. So 44% reduction in infection rate, 68% reduction in mortality. And when we actually look at the deaths here, there was 25 deaths in the ivermectin group, 0.8%. And again, that gives us a nice group for comparison. That group there. 79 deaths amongst the ivermectin non-users. So again, we've got the comparison group, 2.6%. So we can see that way fewer people are dying in the ivermectin group. And again, we've got that nice intergroup comparison. The relative risk there was 0.32. In other words, what a 68% improvement, protection effect from death with ivermectin group. Again, chances of that arriving by chance, not 1 in 100, not 1 in 1,000, 1 in 10,000. So we're pretty sure that is a genuine result. And when adjusted for residual variables, reduction in mortality rate was 70%. I mean, why isn't this in the newspapers? 70% reduction in mortality in this study. I mean, this is just huge. And this is with a tiny dose of ivermectin every fortnight, acting as a prophylaxis. You know, why are people not talking about this? It really does. This is why I think ivermectin is going to be one of the huge scandals of this. It's almost as if information has been deliberately suppressed throughout the pandemic, to be quite honest. No one's saying that's true, of course, but it's almost like that. The evidence just seems so powerful, present and overwhelming. I mean, 70%, how do you argue with a number like that? It's a very, very high number. 56% reduction in hospitalisation rate. Again, 44 in the ivermectin group, 99 in the non-ivermectin group. And again, so we've got the two groups for comparison. After adjusting for residual variables, reduction in hospitalisation rate was 67%. So the ivermectin group, 67% less likely to be hospitalised. Again, P equals 0.0001. This result is phenomenally unlikely to have arisen by chance. This is impressive data from this study by anyone's standards. I mean, this really is impressive, and it's all there, it's all written up, it's all peer reviewed. Yeah, I mean, hopefully we might be able to talk to some of the authors at some point. It's there you go. Have we missed a trick with ivermectin? Well, this paper would tend to indicate that is the case. Conclusion: in this large study, regular use of ivermectin as a prophylactic agent was associated with significantly, very significantly, as we've seen, reduction in COVID-19 infections, so less infections, less hospitalisations and less deaths in the ivermectin group. I mean, the people that took ivermectin got less infections, they were hospitalised much less, and they died much less. What is not to like? There you go. Let's see if we get any feedback on that. On terms of feedback, there's two sorts of criticism really. I mean, I've interviewed some of the leading scientists. Professor Højby in Denmark, for example, corrected me on one or two things, which was great. Professor Clancy in Australia corrected me on one or two things, which is great. Completely open to that, 100% open to that. We had a debate, of course, with Professor Tim Spector about vitamin D, and our views diverged, and we had a legitimate, profitable debate on that. But there's quite a few people that are criticising just to get, it just seems, well, you get quite a few people that use, I mean, thankfully, I'm grateful that a lot of you people good people have decided to watch my videos, and that puts the numbers up. So what a lot of people seem to be doing is using my name on their videos to try and, in my view, just to try and boost their views, and they post cynical videos, and it's quite undignified, really. If someone wants a YouTube channel, they can work hard over several years and build up their own, rather than trying to cynically get views from my channel, which I mean, I'm more than happy to cooperate with anyone, happy to debate anyone. But these cynical ones, the undignified ones, I don't watch them, and I wouldn't dream of commenting on them. Now, some of you have sort of tried to defend me on these, but really the best thing to do is ignore them, because they are quite undignified. Let's go for positive, evidence-based, rather than just saying John Campbell's a bit silly. It's a bit pathetic, really. So I would encourage you just to ignore those, really, and look at the evidence as presented here in this particular peer-reviewed paper. That's the way the evidence is, as I understand it, and we'll carry on being positive. You know, the reason that, okay, the pandemic's largely over now in many parts of the world. Okay, Western Australia, New Zealand, Hong Kong. We're not saying it's over. It's going to be endemic for a long, long time, and it is still causing problems. But I've personally suffered from quite a few viral diseases that made me feel pretty bad, and I've nursed many patients, looked after many patients who've died from viral diseases and suffered greatly from viral diseases. So we had another antiviral medication that was cheap and safe, that I would welcome another antiviral medication, and I couldn't care less whether it's on patent or not. The fact that no one makes any money out of it, if it turned out ivermectin is effective antiviral, and no one makes money, but we do save lives and alleviate human pain, suffering and death, I for one would be delighted. Thank you for watching.